hypoglossal nerve at Cleveland Clinic in Cleveland, Ohio. He completed his medical college from NHL Municipal Medical College in India and immigrated to the United States soon after. His educational journey continued with a Master's of Public Health at Cleveland State University, a pediatrics residency, and sleep medicine fellowship at Cleveland Clinic. Before he joined as a staff physician at Cleveland Clinic in 2016, since then, his clinical endeavors include managing the spectrum of sleep disorders across all ages in pediatric patients and adults as well. Additionally, he has extensive experience in managing patients with hypoglossal nerve stimulation therapy. He manages over 100 adults and more than 4 pediatric patients. For OSA management, he also manages patients with continuous positive airway pressure who are intolerant in these settings. He has published in peer-reviewed journals and nationally presented on outcomes in hypoglossal nerve stimulation therapy. He's a mentor. He's a continuous source of inspiration and family to me. So please give it up to Dr. Shah, who's going to be presenting Integrating Alternate Adjunct and Emerging Treatments and Management of Complex Pediatric Obstructive Sleep Apnea. Thank you.
Good morning. It's nice to be in a nice sunny, little bit warmer area compared to where I come from. And thanks for the opportunity and the generous introduction, Dr. Lozada. So let's dive into this topic right away. It's one of the topic at my heart. I do not have any financial disclosures. These are some of the glossary terms I have used. It's available in your slides. It's most common one. So hopefully if you have a question, let me know afterwards, but should be okay through the presentation. What are we going to learn today? So we're going to understand the role of phenotyping obstructive sleep apnea and applying to the management decisions. We're going to learn about the various treatment options, including the most recent cutting-edge treatment, which is hypoglossal nerve stimulation, and strategies to implement multi-modal approach in treating obstructive sleep apnea. So first of all, I'm probably not going to go through what is obstructive sleep apnea. I hope most of you understand the basics of the pathology that it's an intermittent upper airway obstruction due to a variety of risk factors and pathologic mechanism. How do we diagnose? So typically it's combination of the clinical presentation as well as polysomnogram, which is a multi-channel study. A typical polysomnogram includes 6-lead EEG, EOG, EMG, at least 2 respiratory sensors, including end-tidal CO2, the respiratory effort or BELS, pulse ox. Some may include transcutaneous CO2, some may not. Video monitoring and other channels. So typically it's a multi or a polygraph, which provides a lot of good details at the night time when child is sleeping into their breathing and other aspects of sleep. How do we define severity of OSA? So the term called AHI, I'll use frequently in this particular presentation to familiarize with that. AHI stands for apnea hypopnea index, which is basically in 1 hour of sleep, how often child has complete closure of airway defined as apneas or partial closure with a consequence such as an arousal. Arousal is an EEG phenomenon where brain is woken up and or a desaturation at least 3% from the baseline. So that's called hypoapnea. So the index means in 1 hour how often a children would have those events. In general, less than 1 time an hour is considered no obstructive sleep apnea. 1 to 5 is mild, 5 to 10 is moderate, greater than 10 is severe. Typically, there are no clear universal cutoff. This is based on guide based on widely accepted research as well as clinical experience. The critical important part is when you make clinical decision, it is not only the numbers, it is the clinical presentation as well as supporting polysomnographic finding. And that's the key to understand here. Why do we care? Why do we need to treat obstructive sleep apnea? There are 3 mechanisms by which obstructive sleep apnea leads to several consequences. 1, intermittent hypoxemia. 2, sleep fragmentation, which is due to the increased number of arousal or full awakenings, and alveolar level hypoventilation. Consequences for obstructive sleep apnea tend to be 3-fold in children. 1 is cognitive and behavioral or neurobehavioral, which I think are the most important ones and most studied and known, and that's the one I'm going to highlight today. There is some mixed evidence about the cardiovascular consequences as well as metabolic consequences. In adults, there is significantly robust evidence to an extent for hypertension, that we think it might be a causal relationship with the moderate to severe obstructive sleep apnea. But in children, it is not established yet. There are papers about higher level of blood pressure in children, but not yet consistent finding and so on. So what are the cognitive and behavioral consequences? There is robust research evidence showing it can lead to hyperactivity and inattention. There is a trend towards dose-response relationship. That means higher severity of obstructive sleep apnea, higher degree of the symptoms as well. Behavioral problems such as aggressiveness, oppositional or conduct problem. Daytime impairment such as slow reaction time, impaired vigilance or sustained attention. Lower academic achievement and learning problem. A child's job most of the time is to learn, right? That's the most important part they spend their early life into. So this is really important to understand why obstructive sleep apnea is important. And good part is adenotonsillectomy can reverse many of the symptoms, and there is an evidence behind that. This evidence is robust enough that at least I believe there is a direct causality, not just an association between obstructive sleep apnea and these consequences. There is limited or mixed evidence about other consequences associated with obstructive sleep apnea, particularly cognitive deficit, clinically meaningful lower IQ, executive functioning such as problem solving, verbal reasoning, and or multitasking. There is no clear yet evidence that obstructive sleep apnea leads to memory problem in children. There are certain populations who are at very high risk of having obstructive sleep apnea and or having consequences due to obstructive sleep apnea. Adenotonsillar hypertrophy in children without any other risk factor. Obesity, which is quite prevalent at the moment. Certain genetic syndrome, for example, Down syndrome. Pretty much within these three, your 80 to 90% of population who have obstructive sleep apnea resides within these three bucket of the risk factors. Craniofacial anomalies, Treacher-Collin, Pierre-Robin, other type of anomalies, and neuromuscular diseases. There is a bidirectional relationship with asthma. Asthma does not cause obstructive sleep apnea. However, the end consequence of hypoxemia in children from obstructive sleep apnea and asthma, particularly if untreated, both of them can lead to significant problems and so on. The ADHD, about a third of the children have obstructive sleep apnea and vice versa. We do not know yet whether there is a clear causal relationship with the full spectrum of ADHD between OSA leading to ADHD. However, in clinical practice, we find that if children have ADHD and moderate to severe obstructive sleep apnea, they tend to have worse symptoms, and treatment of OSA does lead to improvement in the ADHD symptoms. And then children with sickle cell disease, again, are not at high risk of developing OSA, but if they have concurrent OSA and hypoxemia, it could lead to consequences from the sickle cell disease itself. So that brings to the meat of this particular talk. What are the treatment options and how do we implement into our clinical life work? For a number of years, adenotonsillectomy has been first line, and it is still the first line treatment. And pretty much it's going to apply to majority of the patient you'll see. CPAP is considered a second line right after that. And this is what the armament we had until about a decade or two ago. As described on the right side here, like an engineering toolbox, one of my mentor always described that nowadays we have a big toolbox instead of only a couple of hammers to treat obstructive sleep apnea. And that includes number of the treatment options here, which includes obesity management, dental treatment, particularly rapid maxillary expansion, medications such as nasal steroids and or montelukast, neuromodulation, which is hypoglossal nerve stimulation, number of surgical procedures, which include drug-induced sleep endoscopy and or multi-level surgeries. In some extreme cases, patient we need tracheostomy. We also have few on the horizon, oxygen via high-flow nasal cannula. There are a few papers on that, but it's not ready for the prime time yet. Oxybutynin and atomoxetine, as well as GLP receptor agonists, which are utilized for the weight management. So the ones highlighted in green and red here are the one I'm going to cover today, but I'm happy to answer any questions regarding the other ones. So this is 2012, when the last AAP guideline to treat obstructive sleep apnea was published. And I think it is true to still to an extent, except the fact we have grown a lot after that. The AP said if you are moderate to obstructive sleep apnea, adenotonsillar hypertrophy, non-obese patient or non-high risk, which I showed you earlier, refer to ENT for evaluation and for possible adenotonsillectomy. If you don't have adenotonsillar hypertrophy or have obesity and or high risk patient, consider other modalities such as CPAP or weight loss must be the part of the plan, or consider referring to a sleep physician, right? So there are only two tools provided here for these particular options. For mild obstructive sleep apnea, judgment is based on the clinical presentation. Generally, by the time they come to sleep clinic, they are usually symptomatic, and therefore we tend to treat them more rather than not treat them. Watchful waiting is still an option in mild obstructive sleep apnea. You have option of nasal steroid and or Montelukast if it is age appropriate. You're going to reassess them after a few weeks, about 6 to 8 weeks after starting the treatment. You can refer to ENT and for a possible adenotonsillectomy. And there is some evidence in most recent study, which some of the results will come out, called PET study and so forth. So these are the options you have based on the degree of obstructive sleep apnea. However, I'm going to present within this a little bit different point of view in a second. So where did we come from adenotonsillectomy? Our landmark trial was called CHAT study, which is the children adenotonsillectomy for childhood obstructive sleep apnea. This is our first randomized control trial, and that led to the current standards of treatment for OSA. It included children with snoring, 5 to 9 years, moderate to severe obstructive sleep apnea. They had obese and non-obese children, and that's an important part to understand. They randomized into two groups, said watchful waiting for about 7 months, and the second group was early adenotonsillectomy, 1 month right after the diagnosis and so forth. The light blue color here is the watchful waiting group, and the green color here, dark green color here is the adenotonsillectomy group. First, looking in non-obese children, it is effective almost 85%, so it does work and so forth. Interestingly, in this population, if you wait for 7 months, half of them may also have improvement by the objective data such as AHI. In obese children, as you can see, the effectiveness is less, particularly waiting leads to much less effectiveness and so forth. There are other clinical outcomes with variable effect size, means it may be dose dependent or other size of the effect. It does reduce sleepiness. It does reduce other obstructive sleep apnea symptoms measured by what we call sleep related breathing disorder scale. It does improve global executive functioning. It does improve behavioral scores, particularly in the child behavioral checklist, particularly in the domains of attention and aggressiveness. And it does improve general quality of life. So there is a lot of good data, and there are subsequent papers and studies after this confirming this particular study's finding and so on. What happens if you have moderate to severe obstructive sleep apnea and then you treat it with adenotonsillectomy, still have persistent obstructive sleep apnea? Based on the literature, you look the rate, how much is it prevalent? It ranges quite a bit, 27 to almost about 80%, depending on the paper you read and so forth. Who are at more risk of having persistent OSA? That's when the obese children or patients who had much higher degree of obstructive sleep apnea at the baseline, really in the severe or really severe category, we sometimes call it uber OSA, or congenital anomalous craniofacial abnormalities and or genetic syndrome. So those are the ones you want to keep it on your radar and follow them up after adenotonsillectomy, probably within 2 to 3 months. And make clinical decision whether they need polysomnogram or not. AP guideline does say for the severe obstructive sleep apnea, they should get a repeat polysomnogram. What options do you have if you are in this situation, right? There are basically two options. Either you have positive airway pressure or certain diagnostic evaluation-based decision-making. That is either through the DICE, which is drug-induced sleep endoscopy. Certain centers utilize what we call cine MRI and other type of the investigation. Some centers utilize lateral neck X-ray. We do not utilize MRI or lateral neck X-ray in our institution. You can have soft tissue surgery, number of them, hypoglossal nerve stimulation, or bony surgery. And we're going to look some of this in the detail today. So what does CPAP do, right? The magical mask here. Is it effective? By objective data, by AHI for sure. Any children or adults who can use this particular treatment, it does work to a very high degree. It's more effective probably than adenotonsillectomy. Does it reduce sleepiness? Yes, with the variable effect and so forth. Does it improve the child behaviors and or some of the neurobehavioral consequences? Yes, there is evidence about that also. Challenge, our studies are all short term, 3 to 6 months. We do not have long-term studies showing the same outcomes and so forth. And the biggest challenge in pediatric population is adherence and or compliance and so forth. So particularly children with certain type of genetic syndrome, autism spectrum disorder, ADHD, or craniofacial abnormality may have higher degree of intolerance and so forth. With the best of the tools we have out there, it ranges somewhere between about 40 to 60% of patients who can tolerate CPAP, particularly in the older age, there tends to be slightly higher success and so forth. There are typically 3 sets of interventions you can do, either behavioral intervention, either an intense level of desensitization in a clinic dedicated to that, and or technical intervention, and sometimes what we call medical intervention, such as hypnotics and so forth to improve the CPAP tolerance. But even despite that, we do have a challenge with the adherence and so forth. What about the working on the weight management? So children with the obesity, there is evidence behind multidisciplinary lifestyle and behavioral intervention. There are 2 good studies published. These are the ones which consistently had children follow the dietary, behavioral, and modification and or activity modification, and they followed up to about 6 months. Fair amount of weight loss, I'll say sometimes it's not possible to accomplish this much weight loss, but there are patients who will succeed getting here. After the 6 months and this much weight loss, about 38 or 33% in either a study had residual OSA, means almost more than 2/3 patients did have improvement or resolution of obstructive sleep apnea, even with weight loss. About bariatric surgery, right? One study is outside of US, one within the US. After bariatric surgery in adolescent, they followed at 6 months. Huge amount of weight loss here. Other one hasn't reported, but the results, only 10% to 18% had residual OSA. Means it did work almost 80 to 90% of time after the bariatric surgery. So obesity and adenotonsillectomy, right? So what do you do with those patients? These are based on the definition of AHI you take, whether less than 1 success, less than 5 success, ranges between about 34 to 49%. Again, in obese patient, it is less successful. As I said, there is wide variability of how much success you get, but generally is typically with much less compared to the children who do not have obesity and so forth. And then certain literature shows anywhere between 33 to 77%. My clinical experience is about half and half. And most of the paper are suggesting greater than 50% of patients may still respond to adenotonsillectomy, even if they have obesity. So what do I do? What's my experience and opinion here? One, does CPAP work? Absolutely, yes. It's a highly effective treatment. 2, does weight management work? Yes, it's highly effective treatment. Is all the children able to accomplish both of those with adherence as well as the degree of weight loss needing to accomplish? Probably not. However, children who can actually tolerate and or accomplish have chances of cure here. So it is critically important that in your practices you do offer and try as much as possible to work through these 2 particular treatment options because of the effectiveness itself. I get quite a few times question asked, how much weight should I lose in order to cure sleep apnea? Answer is, we don't know. In adult, there is some literature showing approximately 10% body weight loss equals 25% less risk of OSA, but there are no studies in children. So I typically talk to family and say, time will tell, but we know for sure it does help quite a few patients. It's a lot of work, but there is hope there. Okay. What are the dental treatments available? So what you're seeing here is a technique called rapid maxillary expansion. In this particular type of technique done by orthodontic, typically implant the expanders, which you are seeing in the second picture here. And then typically it is at home, a children and or parent is helping to expand every week by millimeter and so forth until certain degree of expansion is achieved. What does it do? It typically increases your nasopharyngeal space as well as the nasal space and creates more effective space for tongue to fit in rather than ineffective place where tongue cannot fit in and then have no room to basically move in that oral cavity and falls back, which leads to obstructive sleep apnea and so forth. There are certain other orthodontic treatments, which what we call mandibular advancement device. Typically, these treatments are also done for certain weeks to certain amount of months by orthodontics, and the effect is analyzed after that post treatment and so forth. This is relatively newer generation treatment for us. There are a number of papers now. One particular paper has shown 12-year out effectiveness by AHI. The other paper, what you are seeing here by AHI, means the objective data, particularly in mild to moderate cases, mixed but positive effect. In general, in practice, I see the same situation. That number of higher percent of patients will have positive improvement in their symptoms and their objective data compared to patients who will not have it and so forth. So another tool available if you need to do it. Most common age is typically most of the orthodontists will wait until after the permanent dentition is accomplished. So the youngest I've seen is about 7 years. More commonly, they tend to implement somewhere between 8 to adolescent age group and so on. What happens after this, right? So if you need to go through the surgical options after that, there are certain level of evaluation you need. It could be either awake endoscopy, which we do quite a bit at our center, physical exam, of course, for sure, cine MRI, which we haven't done a whole lot, and then drug-induced endoscopy, which we utilize quite a bit for the surgical research. This is an example of cine MRI. You can see both anteroposterior and concentric collapse here at the level of the soft palate as well as the tongue base and so forth. And it's a classic example of the obstruction. What is drug-induced sleep endoscopy? In that particular procedure, typically our ENT, certain centers or pulmonary provider who will take children to OR and induce close to sleep-like state with light sedation, typically by propofol or other agents and so forth, and perform the upper endoscopy and so forth. And they're trying to look at what level and what degree of obstruction they have, typically looking at the nasal, nasopharynx, tongue base, and epiglottis level. And based on that, it can help you guide further what kind of treatment to offer to the patient. Who should go through is still debatable. There are still guidelines coming out. I don't think so we are there yet on a consistency on which patient should have. But these are the patients who should, in our clinical experience, go through persistent pediatric obstructive sleep apnea, children without obvious areas of obstruction, such as adenotonsillar hypertrophy or nasal turbinate hypertrophy, which you cannot identify on the physical exam. If you don't have it, you're like, okay, this is still moderate to severe obstructive sleep apnea. There is something not right here. Those are the ones you should send for the DICE. Children with significant comorbid conditions, particularly genetic syndrome or the craniofacial anomalies, and then if they have state-dependent laryngomalacia. Those are the 4 key ones. After DICE, there are a number of different levels of surgeries, one or in multiple level available. And ENT typically makes decision based on what they find in this particular procedure and so forth. The good part, it does help. The not so good part, the effect is highly variable and less successful than other modalities and so forth. So where does it come into picture? It's a tertiary therapy after adenotonsillectomy and CPAP. It's basically salvage procedure for obstructive sleep apnea, and when CPAP and other conservative measures fail. And as I mentioned, success rate wise, it's less successful than CPAP as well as adenotonsillectomy. So you really want to know why you're doing this surgery or not, and make sure that all of the options are probably you're out of all other options. That brings to the newest kid in the block and the cutting edge treatment called hypoglossal nerve stimulator. That's where my current work involves. What does it mean? So as you can see here, there are 5 components. It's an implant. It's a subcutaneous implant. The middle part here, which looks like tiny pacemaker, is called IPG, implantable pulse generator. Then there is a remote. There are 2 sensing lead and the cuff. It's a closed loop system. Typically, there is a stimulation lead, which you can see in the neck here, which encircles the cuff of the cranial nerve 12, which is the hypoglossal nerve in the distal branch. It delivers stimulation from that IPG, means that tiny pacemaker-like device, to the nerve cuff interface. And the sensing lead, which is the inhalation lead, is placed between the intercostal muscles. In the now right below the IPG, usually in the past it used to be between 4th and 5th intercostal space. That is a pressure transducer which detects your breathing. So every time you breathe in, that will send a signal to the IPG, and IPG in turn will send the electrical impulse the hypoglossal nerve, and therefore the action of that nerve, I'm going to show you in a second, but mainly the tongue protrusion. And then typically you have a remote, so patients can turn it at night. We typically programming that remote and so forth, and in the morning they can turn it on. The battery life is about 10 to 11 years, which is a good thing, means that you do not need to go back and do procedures again and again. What does it do? So it's a typically multi-level upper airway obstruction is what it leaves. Primary action is at the level of the tongue, the protrusion, as well as the posterior depression. You can see on the left side here, without any kind of stimulation, very closed airway. All the way on the right side, titrated and therapeutic. This is a drug-induced sleep endoscopy picture. It's a nice and open airway. So that's how typically it acts. It does have some effect on the velopharynx to open up in the lateral position also, but that's a minor effect compared to the tongue protrusion. Who are right candidates? So it got FDA approved in 2014 for adults. Typically, you have to meet certain criteria. AHI in adults need to be between 15 to 65. It has expanded now to 100 as of this year. You have to be intolerant to the CPAP or BiPAP. Body mass index in adult needs to be less than 35. It is now expanded to 40. On drug-induced sleep endoscopy at the level of tongue and or palate, particularly tongue, you have to have anteroposterior collapse because that's when it works the best. It doesn't work very well on the concentric collapse because of the mechanism of the action. And then you shouldn't have more than 25% of your apnea as a central. In pediatric, it got FDA approved in 2023, means last year, for 13 to 18 years only Down syndrome patients. So it's not available to any other population at the moment. You have to have AHI between 10 to 50. You have to have not tolerated PAP and or either had adenotonsillectomy or not candidate for that. And patients with tracheostomy can actually get this device, and actually it's one of the indications because it can help you decannulate if it treats the sleep apnea effectively and so forth. And there is at least a couple of cases described in the literature already. The body mass index needs to be less than 95th percentile. And again, on DICE, you have to have anteroposterior collapse. And then less than 25% of your HI should be central. There is variability a little bit in insurance approval. Pediatric patients, so far, we have not had any challenges, including Medicare. So that's a good sign here. And then there is no clear BMI limit. This is what we know currently from the literature. That's why those limitations are set. In clinical life, we do see a dose-dependent relationship, means higher the BMI, lesser the effectiveness. We do not know the reason yet, but we believe it may have to do with more concentric collapse in those patients and so forth. As we unfold the research, we'll know why. So how do patients get in? So you screen the patient, they have drug-induced sleep endoscopy, determine the candidacy, they get the implant procedure. Then they come back to our sleep medicine and we programming and what we call activation of this device. We let them get used to it over 3 to 6 months. And after that, we send them back to our sleep lab to fine-tune this device to figure out what particular setting treats the obstructive sleep apnea optimally. And then if all goes well, they go to the long-term management. So how did this therapy come into picture, right? It has to have some good outcomes. So these are the outcomes from the pioneer study called STAR trial, stimulation therapy for apnea reduction in adults. What you're noticing here is the reduction in snoring. So the dark green is no snoring, light green soft snoring, yellow loud snoring, the orange very intense snoring, and that red button is lives room snoring. So quite intense. On the first bar, you can see there are quite a bit number of patients who had significant snoring. 5 years later, in 60 months later, on the last bar, you can see about 40% of patients had no snoring. About 50% of patients had soft snoring. So the degree of snoring had reduced. And 10% still had intense snoring and so forth. This is pretty much what we see in adults with this therapy. The same trial looked at the objective data, such as apnea hypopnea index, which is in the blue bars, starting in the severe range in adult, all the way coming down to mild range at 5-year interval. Functional outcome of sleep questionnaire, or also known as FOSQ, that is a quality of life questionnaire, how much your quality of life is impaired by obstructive sleep apnea or sleep problem. You want improvement, and above 18 is considered good quality of life. So number of patients had impaired quality, gradually improved and maintained. And then the Epworth sleepiness scale, which is a subjective scale for sleepiness, which is in the orange bar here. Typically above 10 is considered clinically significant sleepy. That improved and came back to lower than 10 and ranging about 6 in this patient. So that's how this therapy got FDA approved in the adults. What happened to the pediatric? What led to the FDA approval? This was the main and pioneer study, which got published in 2022. 42 patients, those criteria they met. Their baseline AHI, the mean was 23.5. Post-therapy at the time of titration and optimization came down to 11. Now, when I look at as a pediatric sleep provider, I cringe on it, right? Because, well, you still have AHI greater than 10. Why are we doing this, or why are we treating with that, right? If it is that's the situation. And the key here is children with Down syndrome have one multi-level obstruction, very high risk of obstruction. And many of them have very severe obstruction where they may run out of every other option. You're left with tracheostomy or not, right? So in my opinion, this particular treatment is gonna become or has become part of a multi-modal approach and or even though it may not completely cure or control sleep apnea, it may reduce the degree enough to reduce your cardiovascular risk and or improve the symptoms. And that is the reason this tool is available now for the pediatric patient. It did have impact on sleepiness, and we do see that in the clinical life also, that patient-reported outcomes are better compared to the objective outcomes in pediatric population. And these are patient-reported outcomes. So OSA 18 is an instrument which looks at, again, quality of life impairment due to obstructive sleep apnea in pediatric patients. It did show quite a bit improvement. So did Epworth Sleepiness Scale. And therefore, they're better quality of life and they're less sleepy, consistent in the clinical practice. And so where do I stand on the surgery, right? So first, hypoglossal nerve stimulation, in my opinion, is somewhere going to be in between CPAP and other surgeries, your tracheostomy. I think it's going to be above that, and because of the nature and how the therapy is set. Also, as I mentioned, it's going to become part of the multi-modal approach, means at same point of time, more than one particular treatment you can do. And that's the point I'm going to make at the end of this presentation, is where it's going to come into picture. The other surgery, typically, I suggest keeping it when everything else fails and so forth. So that's where I am with the current literature. Medication-wise, right? So two popular ones, intranasal corticosteroids and montelukast. There is fair amount of evidence, or at least research, in last about 10 years. However, the evidence is mixed about intranasal steroid. We do think in mild cases, it does improve symptom. One of the Cochrane reviews said insufficient evidence. However, the AHI in mild cases did have some improvement, as well as symptom had some improvement, not in all the patients. The other study came out and said no difference in AHI after 3 months of use, right? So again, mixed evidence here. Montelukast, as you know, it's a leukotriene receptor agonist. Both of them are anti-inflammatory medication, and that's how they improve the airway patency, particularly at the level of nasal inflammation and or adenoidal inflammation, if you still have adenoids present. It did show that at a 3 or 4 month interval, it did improve by objective data AHI in mild or moderate cases. It did not help as much as in the patients with Down syndrome, and that's also our clinical practice. Last but not the least, if you use only oral montelukast versus combination of oral montelukast and inhaled corticosteroid, it seems we have better response with the combination when it comes to objective data such as AHI, and better response in terms of the oxygen desaturations are concerned. Means you have improvement in oxygen desaturation if you utilize combination. My take, I generally, if I put patients on this, I'm a little bit aggressive because both of these medications are known to pediatric for a long period of time. Overall, the beneficial effect are more compared to the risks here and so forth. So where should it be utilized, right? One well-tolerated, montelukast does have black box warning as of 2019, as you may know. If you dissect down that particular literature, it says the young adults who had pre-existing either depression and or emotional difficulties, it can increase suicidality, and therefore it led to that black box warning. On my extensive search, I have not found any particular paper which shows that exact same result in pediatric population. So if your parents ask, I do talk to them about in detail. We do find 1 in about 20 kids may have some emotional side effects, particularly increased irritability and or hyperactive and or aggressive behavior. But outside of that, overall, I found to be fairly safe in pediatric age group. So if you have, it works Well, if you have comorbid allergic rhinitis and or asthma, so allergic rhinitis for inhaled corticosteroid, asthma for montelukast, those are the patients you want to particularly consider, particularly if they have mild obstructive sleep apnea or mild to moderate obstructive sleep apnea. Most the patient or family may prefer though adenotonsillectomy over this because of the success rate. But time to time we get families who do not want to go through surgery. So we do have this tool available in mild to moderate cases, particularly the mild cases. So where are we going, right? So GLP-1 again is the miracle drug being marketed at the moment. These are your weight loss medications and so forth. So semaglutide, liraglutide, and so forth. And then atomoxetine and oxybutynin. Particularly semaglutide and liraglutide. So in obesity in pediatrics, liraglutide had shown, and both have shown similar result as adult, fair amount of weight loss. In obstructive sleep apnea in adults, liraglutide particularly has shown significant improvement in AHI to an extent that right now it's in FDA for FDA approval as for obstructive sleep apnea as an indication to go on these medications and so forth. And probably we'll know within about 6 months or a year of time whether it gets approved in adults for that. So far, it has been FDA approved for diabetes and obesity both. This is going to be the third indication and so forth. So probably we are 5-10 years away in pediatric age where it becomes available to pediatric for OSA as an indication. So atomoxetine and oxybutynin, it's FDA approved for ADHD purposes as an Strattera is the brand name it comes with, or oxybutynin about 6 years, particularly for the overactive bladder. Atoxy is combination of this. It is what we have seen in the research is it increases the upper airway muscle tone during the sleep. And in adults, in mild to moderate cases, it has shown about 50% improvement in AHI. It's in phase 3 clinical trial in adults. And in the pediatric age group, the NIH-funded first trial in Down syndrome is going on in Phoenix, in Arizona, in the Banner Health, and so forth. About 10 patients. The results are not out yet, but I have seen the results from the author and so forth. And this actually slide is from that particular provider, and it seems positive result. There are side effects here. So at some point, this may become part of our armament to treat obstructive sleep apnea, which in my dream, I didn't think it will happen, but it's happening at the moment. So coming back to the original idea, right, of this big toolbox you have. So we reviewed number of treatment options here. Now, how do we decide what to pick, right? That's a big question here. Where to go and how do we tease all this out? This is the key this is where I think the field of pediatric sleep going towards. We utilize this in our clinical practice quite a lot. So you want to learn to phenotype patient, starting with the red down their clinical presentation. Do they have neurobehavioral symptoms? Do they have sleepiness? Do they have nocturnal symptom? Are they asymptomatic besides snoring or happy snoring? Identify risk factors such as obesity, genetic, syndrome, craniofacial, or other. This two pretty much will give you two group of phenotype. One, children who do not have any of those risk factors, have adenotonsillar hypertrophy, and are typically developing and or no other contraindication. So that's your one group, and everybody else in the second group. Okay. You want to get the PSG on those to figure out what degree of sleep apnea do they have and what other abnormalities they may have. And what other comorbid conditions do they have, such as asthma, allergic rhinitis, any other cardiovascular or neurological condition. That's going to help you pretty much decide where to go. Group 1, most likely without risk factor, still that AB guideline stands true, which is adenotonsillectomy. Group 2, however, this is my strongest opinion, is where we should go. We used to have this linear approach, adenotonsillectomy first, CPAP after, and everything else after that. Instead, having a multi-modal, multidisciplinary approach from the get-go, from the day one, means plan out the treatment. And that is what pretty much we have adapted. You want to have the team of individual on board, your surgical team, ENT, plastic surgery, oromaxillary facial surgeon, medical team, sleep provider, primary care weight management team, dental team, orthodontist, and last but not least, the most important team player, patient themselves. Patient preferences influence a lot of treatment option, which I'll show in an example in a second. It takes a village. However, that's what is the best outcomes, probably long term, in particular that phenotype which is not the straightforward or complex obstructive sleep. So it has to work in practical life, right? So these are two practical real life cases where we have utilized this approach for long-term success. This one is published. I'm senior author on this one, so I'm going to go through how it worked, all came together. This is a 5-minute window from the polysomnogram. And what you're seeing here is down here, if you see the blue lines, those are apneas. So basically, I was right out of fellowship within my first year. And there are a few cases which gives a sleep doctor insomnia. This is the one which gave me that. I was seeing this study and the AHI was 175. I've never seen this. I'm like, patient is not breathing basically. This patient presented to us directly with acute stroke. 16 years old, severely obese, no other risk factor, never had hypertension, had later on mildly elevated blood pressure, but not in the range of hypertension. Was on OC pill, all other coagulation panels were negative. So we were not sure why the stroke happened. Came to ICU, got stabilized 10th or 11th day, was hemiplegic. We couldn't even get to the sleep lab. We had to get the Hoolier lift and get to sleep lab to even study this. And this is what I saw. So I went to my senior pulmonary mentor and who was teaching me. I'm like, this is what's happening. Am I reading this right? And he goes like, absolutely right. This patient is going to die. I'm like, wait, like it just completely sent me into panic attack, right? After involving that village, we talked to patient and said, you need a tracheostomy. Patient was on BiPAP at the time, so it was safe, monitored in the hospital. Well, guess what? The patient is the most important part of the team. Family and patient had significant taboo about surgery and absolutely refused after 7 days of trying to pursue all this. So team came together and said, well, we have to send you to a rehab hospital. It's very risky for us to send you home and you'll have to show us that you're going to wear the BiPAP. Patient stayed in the rehab hospital for 4 weeks. One of the sweetest patient I ever met and was really trooper. Every night, put it on BiPAP. Okay? And she did. Also, tonsils were 4+, but we were worried in the acute situation with that degree of sleep apnea. If we send to surgery, we may not be able to get extubated and may have severe complication. Therefore, we did not send for adenotonsillectomy. So on the red ones are the clear and important markers. So first is weight status, right? So body mass index very high, 367 pounds is where we start. After 550 days, about a year later, with intense treatment, we are down only almost about 80 to 90 pounds. The green part, AHI, which is the objective indicator, 175 after the weight loss, down to 40, after weight loss and adenotonsillectomy, down to 5.6, and so forth. So quite a bit results here. So how did all the multimodal approach came into picture? This is actually journey. In the red here is reduction in weight. And in the blue, blue here is the reduction in weight, and the red here is the reduction in AHI. In the timeline, this is what happened with adenotonsillectomy later on, about a year and a half into this. She was followed by a number of subspecialties, including our weight management clinic. I personally went there in that clinic at that time, providing services there. But throughout this journey, simultaneously, she was on bilevel PEP, had nasal steroid, had tertiary care weight management, and stroke rehabilitation. We did offer other treatment, tracheostomy, orthodontic treatment, bariatric surgery, anti-obesity medication. Patient basically refused for any of those, at least agreed to adenotonsillectomy itself. Patient is now adult, still alive, thank God, and is wearing BiPAP and has continued and continues the weight loss journey at the moment, but has somewhat plateaued. So one of the key multimodal approach or the real life case. The case number 2, this is a child with Down syndrome who came to us very early into age, about 9 years. Between 9 and 17 years, there are multiple treatment. Patient had very severe obstructive sleep apnea. On the left side here, you are seeing actually body mass index percentile graph. And as you can see, we are starting at on the ceiling, way above 99th percentile for the age and height on the Down syndrome curve and so forth. Patient had adenotonsillectomy, 2 rounds of CPAP, couldn't tolerate, rapid maxillary expansion, then a round of BiPAP, still couldn't tolerate. Obesity management, so tertiary care clinic, again worked with me. At that time, Orlistat was the only anti-obesity medication which was FDA approved. So a lot of lifestyle modification plus that, and that led to on the graph, what we are seeing is downward, the significant weight reduction in her, and this is the current situation where she has basically maintained the weight on this. Then still symptomatic, right? Despite this many treatments. So we sent for drug-induced endoscopy, had enteroposterior collapse. At this point, we are not left with any other good option. Most recent, after all this, the polysomnogram that did show still OSA with HI in severe range, had hypoxemia, has snoring, has intermittent sleepiness. What did we do? This is our first patient who we had hypoglossal nerve stimulation implanted at the age 70. She's currently 6 months post-implant. She's utilizing 9 hours average, which is amazing compared to any other adults who goes through this therapy and so forth, or compared to CPAP. Sleepiness is subjectively improved about 70 to 80% per family and patient. HI is reduced from 15.5 to 3.8, and hypoxemia is improved. So another example of how multimodal treatment came into picture and all came together. So key takeaways, not one size fits all when it comes to pediatric obstructive sleep apnea management, particularly complex obstructive sleep apnea. Phenotyping is key. So please phenotype. That's going to be your guiding light. It takes a village. I think the future is individualized, multimodal, multidisciplinary approach. That's what's going to lead to the best outcomes. And pretty much we have started adapting that. An alternative emerging treatment option can be and should be considered at the beginning of planning the treatment as a medical home for the patient. So you want to consider those. There is no contraindication to doing 2 or 3 therapy at this time. I have not found any. I found mostly helpful to do so. Okay. Thank you, and I hope this was helpful to review. So I'll be happy to take any questions.
Would that maybe just for the weight loss, the traditional method, like dieting?
Sure. Yeah, so we have something called BWell clinic, which is an intense tertiary level clinic. It's a SMA, shared medical appointment with a clinician, dietitian, exercise physiologist, and a behavioral health provider. So this patient tried for about 3 to 6 month lifestyle modification, had some success, but not significant enough. Orlistat was actually FDA approved about 10 years at that time, and still is approved for the weight loss. It's not the highest effect, but it has some modest effect and so forth. So that's the one we utilize as an adjunct to the lifestyle modification. None of the medications work without lifestyle modification. So you do not want to prescribe them. You want to have lifestyle modification as your first line treatment.
Dr. Shah, your experience in literature researching hypoglossal nerve stimulation therapy, have you found any outcomes in terms of IQ, therapies?
Yeah, so that's what I'm presenting in the next one. But there is a
in the Zoom audience, I want you to repeat the questions.
Yeah, sure. Let me repeat the question. Dr. Lozada asked, in my experience in hypoglossal nerve stimulation therapy, is there any literature in improving patient outcomes such as IQ or neurobehavioral outcomes, which I'm presenting after this to a smaller group? There is one paper with 9 patients, which has shown early trends in improvement. It's small, but encouraging and very good. That is also my research actually in the future and so forth. So there are more probably literature and paper to come out. We are very early into this from the therapy itself standpoint.
The second question is combining CPAP therapy with hypoglossal nerve stimulation and other therapies all together, especially these very complex care patients with syndromes. What's your experience? What are your thoughts on it?
Yeah, I'll give you both my adult, because that's extensive, I have it, and then some pediatric. So on the adult side, CPAP and hypoglossal patients I inherited were accidental. So because your indication itself is CPAP intolerance, right? But what ended up happening on a couple of cases was very high pressure needs were leading to intolerance. We put them on we got the hypoglossal nerve stimulation at very high settings were needed, even on stimulator, to treat sleep apnea, which led to intolerance to hypoglossal nerve. So when we tried unique and said, let's try both at the lower level, and that's what worked. And patient was like, I had best sleep now. So we said, okay, let's not rock the boat if this is working for you. So we studied with those two in the lab and objectively also, and that's what happened. More so what I'm interested in, I have at least half a dozen patients in adults who have hypoglossal nerve stimulation, oral appliance, and position therapy, and so forth. And again, like patient decision making, right? So patient came in and never told us that had oral appliance. Later on, after implant told us, and same situation at a very high setting, hypoglossal nerve stimulation was needed to treat sleep apnea, which led to intolerance. But when we combined it, led to pretty good outcome over that. So patient is at this point happy. Pediatric side, the one case I presented. The second one is a child with Down syndrome, very severe insomnia actually. They have other comorbid condition. So we had to get that under control. It took us almost a year and a half or two before. And at this point, patient has implant, symptomatically substantially improved, very severe sleep apnea, almost HI50. The challenge in that situation now is we couldn't study back in lab because of insomnia. So now what we are trying to do is go out of box and say, can we do dice-driven programming in the OR to figure out what level of opening are we seeing, and then send patient back with a limited channel study and or multimodal treatment options, because I've tried atomoxetine, oxybutynin off-label there. Number of other treatment options. Only treatment option is left is this or tracheostomy for that patient. So I do think, and I think hypoglossal nerve stimulation alone there is data about half of the patient, it will help or completely control OSA, but the rest are going to need probably additional treatments with that.
Okay, I've got a couple of questions. One is, for the average kid you see in pediatric clinic that's snoring, is there any data out there that says, I mean, are there kids and adults that snore, but they don't have any problems with apnea, or like what percentage of our snoring population actually needs, has bad enough sleep apnea that they need treatment?
Absolutely. So yes, there is actually data. It's reverse way around outside. So everybody who has sleep apnea, 80 to 90% of them snore. And if you look at just snoring data, the 70 to 80% have sleep apnea, but only half total person have moderate to severe sleep apnea where they require aggressive treatments. The rest of those 30 to 40% who are in mild range, my general opinion is if they are snoring and do not have any other symptoms, you do have option of watchful waiting based on the checks there. Otherwise, you can treat with the conservative treatment first and so forth.
And then the second question is, when you're, again, a general pediatrician in clinic, there's kind of, and you are concerned about sleep apnea, you have three choices. You can either send them straight to the ENT doctor for a surgery. You can send them to a pulmonary doctor, which, as we were talking before this started, the problem is there's a big wait time and hard to get in, or you can order a sleep study yourself. So can you talk about what the practice is in Cleveland and kind of what you would?
Yeah, so there are labs across the country which are either open or closed lab. Open means any provider, non-sleep provider, can order a study and get the results. That's what Cleveland Clinic is, because even though you order the study, a sleep physician and or a nurse practitioner will review and protocol according to the clinical history to make sure appropriate studies run. So, and that will override any study you will order and so forth. Versus certain institution have closed lab, means you have to see a sleep doctor before getting the study. Both are right practice. It depends on what access you have. Now, access is challenging at times. So I generally say snoring alone does not get me out of the bed. Snoring plus at least one, minimum one, which is either nighttime or daytime symptom, particularly ADHD-like and or sleepiness or frequent nocturnal awakening, and or at least one of the high risk situations. Those are the ones you want to act upon. If you have access to polysomnogram, get that first if you are comfortable interpreting based on what we talked about. If you do not have it, you can either or send to sleep doctor or ENT. ENT literature, it does not mandate polysomnogram in every patient, and that's taking into account entire country where some of the remote areas may not even have a pediatric lab available, right? There is in the guide, AAP guide in 12, they have said, can you do just a pulse ox? What they came up and see is great evidence, grade level D means not good enough data, but if you have to utilize due to lack of anything else and you need objective data, you can utilize that. as a home pulse ox and so on. So if you have access with that, probably go for polysomnogram if it's open lab, if not either ENT and or sleep doc. For us in sleep medicine, we don't get straightforward sleep apnea because our pediatric team has been very much intending to send them to ENT first. Our ENT team is very good at teasing this out and sending or determining which route to go. So typically we get them after adenotonsillectomy most of the time.
Thank you.
Mhm.
One more minute. 5, 4, 3.
Anybody
Okay,
online has
chat,
question?
okay. Don't see anything in the chat, so I'll call it here.
Thank you.
Thank you very much.